Thank you for the kind introduction. First of all, I would like to thank IMA and ISSBT for giving me a chance to come here and discuss a very important topic. Especially, I would like to thank Siddesh, who has taken great pains and efforts to arrange this wonderful conference for the first time in the city of Nasik. I really congratulate him. I think in time is a constant we already made. So, thrombophilia, I think the word itself can be confusing. Not only for the physicians, but sometimes as a trainee in hematology also they were a bit confusing. So, and most of the time such topics, especially in our MBBS days, we would keep as into bracket option, aya to aya, nahi aya to acha hai. But I think today what we should be learning at the end of half an hour is to the practical aspects of thrombophilia testing, in whom we should do it, and we should be more prudent in ordering these tests when we leave the hall. So without wasting much time, I've got an excellent panelist with a mix of physicians, clinicians, super specialists, pediatrician, and an experienced hematopathologist and a hematologist. So I would start my first question to Dr. Dibendu Dey. What do you understand by thrombophilia exactly?
Hello. First of all, thanks for giving me this to be part of this esteemed panelist. I was a last-minute addition actually. Regarding thrombophilia, thrombophilia is obviously something very difficult to understand because any of the conditions that leads to excess chance of developing thrombosis, that can be regarded as thrombophilia. So it can be any inherited conditions or any acquired conditions due to which patients develops a propensity to have a higher chance of thrombosis in any given situations. So that is thrombophilia. So it is very difficult to understand that because even the age is also a risk factors which leads to increased thrombosis. So even age can be taken as a risk factors for thrombophilia. So all other factors, all other risk factors which leads to development of increased thrombosis, that can be taken as thrombophilia as a group.
Okay, excellent. My next question is to Dr. Khodaji, our senior panelist here. What do you think would be the ideal mix of tests which should be included in this panel of thrombophilia, both congenital and acquired?
Basically, what we do is, depending of course upon the history and upon the age and everything of the patient, we like to get the sample before the patient is started on any anticoagulant treatment, and yet not so soon that the patient is still having an kind of an acute undergoing that episode, and yet we may get erroneous results in both these cases. So our normal screening panel for thrombophilia is protein C, protein S, antithrombin, APCR, which is also a surrogate marker for factor V Leiden mutation, and factor 8, some people think is an independent risk factor for thrombophilia, so factor 8, and homocysteine. So basically these tests cover most of the deficiencies that we come across in our Indian population. Like there is the prothrombin gene mutation which we did, and we realized it is not commonly seen in the Indian population, so we don't do that anymore. So these are basically the antigenic tests, the molecular tests for factor V Leiden mutation, homocysteine, and the other are the coagulation tests. So these are mainly the tests that we include in our panel.
Okay, thank you, madam. Perfect. Next question is again for Dr. Dibendu. I think this is a very practical question I'm going to ask him, and I would like him to elaborate. Is how does thrombophilia testing in acute thrombosis, like if you have an acute DVT or acute pulmonary embolism, does it really change your management initially?
Yes. Basically, for any patients with acute thrombosis, they need a therapeutic dose of anticoagulation for at least 3 months, regardless of whether they have an inherent thrombophilia or not. So for initial 3 months, we do not need any testing to change our treatments. So that's why initial days, it is not required to go for a thrombophilia testing. Secondly, once we start anticoagulations, these anticoagulant medicines can alter the testing methods and alter the results of this thrombophilia testing. So in the acute phase, during the acute phase also there are some acute phase reactants for which there is some changes like changes in the factor VIII concentrations, changes in the other acute proteins, due to which there can be an erroneous result. So in the acute settings, we do not need to go for thrombophilia testing. Once the patient completes the 3 months of therapy, and then they need to know whether they have an inherited thrombophilia or not, and whether they need to continue therapy or not. So that is the ideal time when we should go for a thrombophilia testing.
Yeah, but I think it's a very practical answer. But sometimes, these patients come to our hospital and they have got a cashless suvidha.
Yes.
And when there is cashless, patients say, "Kar dalo sab test, doctor, wo baad mein nahi milega paisa. It's an expensive test." So what do you tell a patient in this scenario?
So generally, we do for a pregnant lady or for a patients who are in a childbearing age group, we do take the antiphospholipid antibody testing at the acute settings in sometimes. And otherwise, I try to counsel them regarding the need for these tests after 3 months, because within the initial 3 months, we can do a part of the test, because not all tests will be completely all right, even with the use of anticoagulants. And we should not delay the anticoagulation because of the test results. That is also one important point.
Hyperhomocystinemia and basically autoimmune disease, if you are thinking, that can be done in an acute setting, not protein C, proteinase or
Exactly. So we can differentiate in acquired and inherited causes sometimes when you order this testing in an acute thrombosis. Excellent. My next question goes to Dr. Manoj Chopra, a senior cardiologist. Do you routinely order thrombophilia test panel in acute coronary syndromes, especially in young patients? What is your approach?
Basically, if you look at the guidelines and indications for the thrombophilia testing, it's only for venous thromboembolism and pulmonary thromboembolism. For arterial thrombosis, as such, thrombophilia testing is not advisable. Only in a group of patients where I see that repeated thrombosis is occurring or multi-system involvement, means a patient is having stroke, then developed a cardiac problem also or a peripheral vascular disease. These are the only patients where we'll advise for a thrombophilia testing. Otherwise, in acute setting or acute coronary syndrome, thrombophilia testing is not advisable, because as such my management is not going to change. And in acute setting, it's basically a low molecular weight heparin or the antiplatelets play an important role than a continuation of anticoagulant. Anticoagulant as such oral, we don't give it. Only patients where the anticoagulant is indicated, where there is a LV clot, or the patients coming after the 1 year with a repeated thrombosis, there we recommend the anticoagulants. Otherwise, in acute setting, it is not required.
Okay, I certainly. So we have got a neurologist in our panel, very own Dr. Bhavishkar. So next question goes to him. I would like to ask him, do you really need thrombophilia test panel, or do you routinely do it in patients with stroke?
So every case of stroke, whether we do thrombophilia workup, the answer is no. But in selected population of stroke, definitely we go ahead with thrombophilia workup. And what is this selected population is? One of them is young and pediatric strokes. So pediatric strokes and young strokes, because we know the traditional risk factors for stroke, which are hypertension, diabetes, then your sedentary lifestyle, smoking. These are not the common risk factors in young stroke. So as a part of workup in this young stroke population, thrombophilia workup is must. It should be done in those population when the traditional risk factors are not present. Second important population, as Dr. Chopra sir told, was basically venous stroke. So unusual site thrombosis, the chances of hereditary thrombophilic factors are very common in that scenario. Okay. We all know that hereditary deficiencies of protein C, proteinase, antithrombin 3, these are common for development of venous thromboembolism, while APLA syndrome, antiphospholipid antibody syndromes, are common for both arterial as well as venous stroke. So if somebody is getting venous thrombosis, whether it is situational also, suppose postpartum is the ideal period, or oral contraceptive pill consumption, even in those cases, regarding the need of continuation of anticoagulation and decide the duration of anticoagulation, I think thrombophilia workup need to be done. And the third population, I will say that cryptogenic stroke, where you could not find the cause traditional risk factors are not present, and even if the patient is elderly, in those situations, sometimes you can order thrombophilia workup.
Excellent, excellent. Yeah, Dr. Chopra wants to add something.
What thrombophilia test you will like to advise? All the panel or selected tests?
If it is a recurrent arterial thrombosis, I will be more keen on acquired thrombophilic factors, so possibly homocysteine levels and antiphospholipid antibody syndrome. Even the criteria for APLA syndrome is very rigid, means not a single titer which is positive. I think at least 12 weeks apart you should repeat the testing, and then only you can confidently conclude. Again, your confidence on diagnosis of APLA syndrome increases if the patient is a female, she has repeated fetal loss. This kind of history, if it is present, then the confidence on making a diagnosis of APLA syndrome becomes much more.
And that means basically acquired and hereditary, that you need to differentiate, and accordingly you can advise the test. That's very important, I think.
So when we talk of panel, it need not be an entire panel. I think we need to
entire panel is not required.
Individualize the tests, and I think that will save some cost and will be more effective. Okay. My next question is to Dr. Pinky Shah, who is a pediatric hematologist here. I would like to ask her about the common causes of thrombosis in pediatric patients and what tests you order for thrombophilia in them.
Yeah, thank you, sir, for the question. Good afternoon, everyone. Usually, thrombosis in pediatrics having a bimodal age group distribution. One peak at the neonate infancy period, and second is at the adolescent period group. So usually causes are whether it's a hereditary causes or acquired causes. Hereditary causes include the antithrombin deficiency, protein C-S deficiency, as well as the factor V-related mutation, as well as the fibrinogenemia and prothrombin mutation. As we think, being a pediatric patient, hereditary causes should be more common, but actually it's the other way around. Acquired causes are more common in a pediatric patient, especially as we have seen that in last 30-40 years, preterm babies, especially sick newborn babies, have improved outcome because of the prominent use of the central venous catheter, catheterization, as well as the interventional procedures. This may lead to increase in the thrombotic events because anyways newborns are a physiologically hypercoagulable state, as one of talk has already mentioned, that they have already a 50% of the protein CS levels than the adult level. So usually newborns having this kind of thrombotic events. Then other causes include the purpura fulminans, which is common in a newborn period with a severe meningococcal infection and homozygous protein C deficiency. Different causes are sepsis, inflammatory conditions, liver disease, as already mentioned, APLA, antiphospholipid syndrome, also common in an adolescent group. These are more common in a venous thrombotic event. Arterial stroke commonly seen in a sickle cell disease and congenital heart disease, especially cyanotic heart disease we have seen. Then certain cerebral arterialization, arteriopathy like Moyamoya disease. Then certain toxins, chemotherapy like L-asparginase, we are seeing more of a sinovenous thrombosis in a CNS. So these are the basically causes for the pediatric patients. Regarding second part, what test we order? Usually basic test we order like complete blood count, PTA, PTT, D-dimer, and test regarding the underlying etiological factors like inflammatory markers, CRP, and viral serology, APLA test, cardiolipin antibodies, and non-imaging imaging test, non-invasive test, we order CT scan, USG Doppler, MR, especially in a stroke, arterial stroke, we advise MR angio. So these are the common tests we order. And regarding the thrombophilia genetic panel, it indicated in very few cases, indicated very required case.
Okay, thank you so much for your answer. I think one thing we are clear in middle of this discussion now, that it's not the entire panel. We have got more of inherited tests, and generally they are referred to as thrombophilia, generally when we talk of thrombophilia. So I think my next question is to Dr. Dibendu. Is there any specific age group in which you would consider ordering this thrombophilia test as a complete panel? You know, age group. I mean to see you've got two patients, one is 16-year-old and one is a 68-year-old with a DVT. How would you order your tests?
Obviously, for patients having an inherited thrombophilia, they are prone to develop thrombosis in a very early age. So that's why in a patients who are at the early age group before the age of 40 years, if they have a thrombotic episodes, or if the female patients having a thrombotic episodes during pregnancy, having a history of pregnancy loss, if a patients who have an unusual site thrombosis like intra-abdominal renal vein thrombosis or portal vein thrombosis, then we try to do all the panel tests for the thrombophilia to look for any underlying cause. So mostly before the age of 40 years, we try to do all the tests to exclude any cause.
So your age limit is around 40,
Around 40,
45.
but obviously if there is an unusual site thrombosis even in elderly, then we can go for thrombophilia testing.
Okay. Guy, thank you. Thank you so much for your answer. Next question is for Dr. Khodarji, and I think it's the right question for her, given her experience in a tertiary hospital in Mumbai. How often you have come across positive thrombophilia tests? How often you have come across positive thrombophilia testing?
Very frankly, because of all the debates that you're having, very few people really send also for thrombophilia testing nowadays. But we do come across positive thrombophilia tests, protein C deficiency, protein S, antithrombin, not so much. And once in a while, factor V Leiden mutation, homocysteine. So we do come across. It's not that we don't, and it has definitely a role to play in the group of disorders that have been delineated for this. You don't do it in all, but you calculate the risk and you do it in those patients, it does come positive. So we have a biased group of patients coming to us, but we do get positive tests.
And I think in some of these patients, it's important for their family members also. Like if you've got a test positive in a family, you can order that specific test in other members.
So actually, our test number has come down, but the ones we do get, and so therefore, obviously, only the ones in which there is high suspicion are being sent to us, and so we do get positive results in those.
I think that's a very good answer. I think we need to be focused sometimes while ordering thrombophilia testing, that it's not a game changer in each and every patient. But yeah, thank you so much. Next question is for Dr. Manoj Chopra. He is the owner of 2 big hospitals in Nasik, so I think this is the right question for him. Do you think thrombophilia test panel is cost effective, sir?
As I said or asked Rahul also, basically what test you want to advise out of the panel is very important. And as I said, in a cardiology or a neurology practice, as such, what we do is a homocysteine and a APLA. These are the 2 tests which we do it commonly. Only patient of a venous thrombosis or a large pulmonary thromboembolism, after giving a anticoagulation for 3 months, after that I try to do a protein C and protein S. These are the 2 tests I like to do. And that also after stopping the anticoagulants for 4 to 6 weeks, and then we order it. Otherwise you get a result which is not equivocal, and you are not able to decide that really anticoagulant is required or not. So basically complete thrombophilia panel, I think very selected cases where the relative is involved, patient is going for pregnancy, or the patient relative has got a history of thrombosis and they are going for a estrogen use. These are the patients which is recommended by the guidelines. Means basically venous thromboembolism and the relatives involved, there is a thrombophilia panel is to be done. Otherwise, acute coronary syndrome, stroke, these patients only homocysteine, APLA, these are the tests required. And protein C, protein S, very selected. So out of thrombophilia panel, cost effective, you have to do it individualized test only. Otherwise, complete panel is not required in our practices. And for arterial thrombosis, it's not recommended. It says that it should be an individualized approach for arterial thrombosis.
Any of the panelists would like to take a call on that? In their current practice, do they see any immediate benefit?
No, for the, again, as Sarah said, that group of tests that can be done in a very selective manner for some of the patients, like in arterial thrombosis also. Also, in some few of the patients, we find that the history of pregnancy loss is there. Then we do all the tests. Otherwise, we may, as I have said, we may defer it for at least 3 months. And we also need to look whether there is, if there is an incident of thrombosis, whether it is because of some triggers or not. And if there is a definite trigger is there, be due to which, like maybe for post-surgery periods in a hip replacement or knee replacement, or if there is any bedridden conditions, then we may not go for a thrombophilia testing in these patients, because these are some trigger factors that is the reason for thrombosis, and these are reversible trigger factors. So that means when the trigger factor is gone, the chance of thrombosis is much less. So in those situations, we may not go for a thrombophilia, full thrombophilia testing in these patients.
Okay. Thank you, Dr. Dipendu. The next question goes out to Dr. Pinky Shah. How often you order thrombophilia test panel in actual pediatric patients? How often have you done that?
So actually, I have already mentioned that acquired causes are more common in pediatric patients. So about 90 to 95% patient, there should be underlying triggering factor. So we usually advise this thrombophilia genetic panel in very few cases, like 5 to 10% patients, especially indicated if any absence of the triggering factor and pediatric patient having a thrombosis with a positive family history, like patient's father or any first degree relative having a stroke, history of stroke less than 45 years, or mother having any thromboembolic event post-delivery. In this patient, if any thrombosis is found, recur, or found in an abnormal region or in a large vessels, then we order a thrombophilia genetic panel. Usually in pediatric patient, this thrombophilia panel is advised by the NGS panel, genetic level. And we usually order after the 3 to 6 months of the first episode, when the patient is off the anticoagulation treatment.
Okay. Yeah.
And usually important, because in a pediatric patient, when patient having a hereditary thrombophilia, then they have an increased risk of VTE, venous thromboembolism, almost 5 to 10% than the general population, as well as the recurrence rate is up to 40% than the general population. So yes, pediatric patients do require this thrombophilia panel test if there is a positive family history, if there is an absence of acquired cause. So we order that.
Okay. Thank you. Thank you so much for your answer. My next question is to Dr. Dipendu, slightly different question. Now, as a hematologist, if you are ordering a thrombophilia testing, you have been asked, and how does that change the long-term management of some patients with DVT or P? How does that really help you in managing those patients?
Actually, what we find in our practice, that very few patients actually comes up with thrombophilia positive factors other than APLA. Probably APLA is the most common cause where we find a patient having a positivity at a higher rate. And if there is a APLA is positive, then according to the guidelines, they should go for anticoagulation. If the APLA is positive with DVT, then they should go for anticoagulations lifelong. Similarly, for other patients also with inherited thrombophilia, if the test becomes positive, which is a high risk thrombogenesis risk, that means if the homozygous factor V latent mutations or homozygous G20210A prothrombin gene mutations or protein C proteinase deficiency, which is significant, that means more than 50% loss, then this patient should go for anticoagulations lifelong, because the chance of recurrence of thrombosis is very high. So in these patients, we can go for continuous anticoagulations lifelong. And for other patients, most of the time, we find only a single gene G2010 mutations like that. In those situations, I think we can go for screening, whether after 3 months there is complete resolution or not of the thrombus. And in these patients, actually risk of thrombosis is much less. So in those patients, we do not need to go for a continuous or lifelong anticoagulations. So we find very few patients who actually need lifelong anticoagulations.
Thank you so much. My next question is to Dr. Rahul Bhaviskar. And this is a question related to the episodes of thrombosis. I think that is a very important aspect when we order or interpret those tests. And would you order thrombophilia test in someone who has got more than one episode of thrombosis?
I think the answer to your question will be theoretically yes, practically maybe sometimes no also. So why theoretically? Because if somebody is getting recurrent thrombosis, if it is an unusual site thrombosis, suppose somebody is getting recurrent cortical venous sinus thrombosis or deep vein thrombosis, in the absence of unprovoked episode, I will say, in the absence of risk factors like DVT, suppose somebody gets DVT, in the absence of major surgery, trauma, or prolonged immobilization. So even in this condition, it becomes an indication for a very long-term anticoagulation. So recurrent CVST in itself is an indication for long-term anticoagulation. So by doing or ordering a thrombophilia workup, practically I am not adding up anything. But if somebody is getting a recurrent arterial thrombosis, then in that scenario, possibly, definitely, as Dr. Chopra sir said, and if the patient doesn't have a traditional risk factors for arterial thrombosis, in that scenario, the selected panel, like your APLA antibodies and your serum homocysteine levels can be useful in those certain population. I think there is a wonderful risk of recurrence triangle. That is what one of the hematological article is there, considering the practical aspect of sending thrombophilia workup, because the cost factor, I think it costs approximately 18,000 to 20,000 if you do the entire thrombophilia panel. So there is a risk of recurrence triangle. In the top of that panel, there are, if somebody is getting thrombophilia, somebody is getting thrombosis in the presence of risk factors like immobilization, major surgery, they don't need long-term anticoagulation. So in that scenario, even if they have underlying thrombophilia, you continue their anticoagulation only for 3 to 6 months. And at the other end, you have situation where you get recurrent thrombotic episodes, unprovoked thrombosis episodes. In that situation, you need to give anticoagulation lifelong possibly in those situations. So there also, there is no use of sending thrombophilia workup practically. So the middle population where there is mild risk factors, little lesser immobilization, a minor surgery. So a thrombosis which is precipitated by minor risk factors or by hormonal things, oral contraceptive pills or postpartum period, I think that is the population where thrombophilia workup becomes very important regarding decision how much duration they should take anticoagulation.
Excellent. Thank you so much. I think we've come to the end of this panel discussion. We've got around 3 minutes left. Now, I think our panelists have done a wonderful job. I'm sure you all would agree. And a big applause for all our panelists. And we have got around 3 minutes for any questions, which I'm sure would be burning in your mind now after having this excellent discussion. So any questions from the audience for our panelists?
Yeah. I'm Dr. Bhagyashri Bora from Pravara Medical College, Loni. Sir, we had one family having familial hyperlipidemia and a child admitted 2 times with a deep vein thrombosis and he had thrombocytopenia. So any condition with hyperlipidemia associated with thrombocytopenia. And
what was the age of the patient?
Age of the patient was 7 years.
7?
7 years.
So it's for Dr. Pinkisha.
Age of patient? 7 years.
7-year-old male child from low socioeconomic status.
Okay.
The occupation was Nandi Bail. They were doing something.
Okay.
So investigations were not possible at Pravara Hospital, but child admitted 2 times with hemiplegia.
Okay. And he had a venous thromboembolism.
Yeah.
Where? Site?
Site, I think, deep vein thrombosis, lower, that is...
Lower extremity?
Lower extremity, yeah.
So usually hyperlipidemia in a family is not a high risk factor for the at least pediatric patients. Usually family history of stroke or MI in less than 45 years of age in a family member we consider as a high risk. So in this patient, I think you should consider the acquired cause. Have you done any markers?
Yeah, madam. I've forgotten to tell one more history. He had multiple xanthomas, and we started atorvastatin also. It was diagnosed case of tuberous xanthoma.
Tuberous
Xanthoma.
xanthoma.
That is very rare. We search
Yes,
it.
actually, it's
Yeah.
very rare case.
Yeah.
But I don't think you should go for the genetic testing because first, it's very costly, and second, it will not change your diagnosis. After 3 to 6 months, you have to give the anticoagulation to this patient. After that, if this patient having a recurrent episode, then you should go for the genetic testing.
Yeah, we have already started atorvastatin, but there was
Okay.
no follow-up of patient.
Okay.
Thank you, madam.
Yeah,
Even in
thanks.
hypercholesterolemia or hyperlipidemia, the platelet counts can be erroneous. So we need to take the platelet counts by slides methods also, because the nephelometry methods or the any optical methods that are used for different tests that can be erroneous. And secondly, hypercholesterolemia that can lead to hyperviscosity, and that can be also a cause of thrombosis. So if the lipid counts improves and then also develops thrombosis, then we need to look into other causes also.
Thank you very much, sir.
Any other questions?
Sir, can I ask one question?
Yes.
I just wanted to know, how do we take homocysteine? Like, how strong it is a risk factor? How do you decide the management? And whether you rely on only homocysteine level or you would like to do mutations? Because homocysteine levels can be increased in B12 deficiency also. We might erroneously label the patient as having homocysteine deficiency.
Yes.
Sorry, hyperhomocysteine.
So I think
Actually, that's controversial. Basically, really does it lead to a thrombosis or not? Here, Dr. R.S. Wadia had a real good work done about the hyperhomocysteinemia and the stroke. And he was very fond of that, the homocysteine leads to a thrombosis. But if you look at the literature, there is a controversial statements about really hyperhomocysteinemia cause thrombosis or not. Some people say that it should be included and it should be treated. Some people say it doesn't make a difference. So it should be again an individualized approach. Basically, that's what the thrombophilia, I think really it's going to change my management or not. And accordingly, you should advise the test. That's what is the crux of this. That's the most important, I think.
I think
you, sir.
yes. I think
can I say something here? Sorry.
Yes,
That
yes.
you must follow it up with an MTHFR gene mutation. If the homocysteine is high, as you're saying, there are many causes. Vitamin B was either that's if the molecular test is expensive, you give a trial of vitamin B12 and then repeat homocysteine, or do an MTHFR gene mutation for them.
But how many percentage of patients or we have that much in population, if you look at it, this mutation, how much we see?
Incidence
basically?
of this mutation.
I don't know. They are doing a study in my hospital in.
Yeah, means,
Recent study has advised that this MTHFR gene is a very common in a normal population also. It may not contribute to the thrombosis as such. It's just a incidental finding in many patients.
yeah, that's what I say.
I think my take will be, I think it has been associated with stroke or thrombotic events, and the intervention to treat hyperhomocysteinemia is simple. So why not to treat it? It is simple. You have to give B6, B9, B12. Give that. What's the harm?
No. Basically, yes, you can treat it, but really is it causes thrombosis or not? It's a controversial. That's what his question was, that basically.
Thrombophilia we diagnose, then the interpretation comes as lifelong anticoagulation. So with that, if we label MTFHR diagnosed, particularly if it's heterozygous, we take it and then we keep on giving these patients anticoagulation. That was the idea about asking this question.
Okay, thank you. I think benefit of time. I think I would like to thank all the panelists for having coming here, sparing their valuable time and enlightening us. And again, once again, on behalf of the panelists, I would like to thank the organizers for giving us a chance. Thank you so
Yeah, I
much.
think we must congratulate our organizers, Rajashree Patil, Prashant, Siddesh.
Yes.
They have done a wonderful job. We should clap for them, I think.
Yes. Okay, thank you.
Thank you.